All right, welcome back, everybody. So we're up next. We have our sponsor presentation. So I'd really like to give a big thanks to all our sponsors. I think moving treatments to our clinical patients is really a collaboration between academic and industry and biotech, and something that I've had a lot of good memories and successes together as a team. And so I think that's what this is all about. So it's a great pleasure to welcome our first speaker, who is representing UCB. So Dr. James Howard will be talking about NMJ damage in myasthenia gravis, point of no return or potential for repair, question mark.
Thanks, Dave. I'm not going to tell you anything new. I'm going to pose to you multiple questions with the hope that I can trigger some interest in some of the junior investigators to latch on to these questions and move this field forward. Yesterday, I showed you the toolbox for MG therapeutics and the rapid expansion in what we have coming in the pipeline through our therapeutic trials. The problem is we now have 5 approved drugs for MG since 2017. We've known about the disease for some 346 years, and we're starting to accelerate in this new transition, if you will. But unfortunately, we've leapfrogged ahead over all of the basic science necessary to understand, in many instances, the true mechanisms, what's going on at the junction, etc. So I'm going to pose to you several questions with the hope that someone will pick up on this and then take it forward with investigator-initiated trials, etc. And so the 2 basic questions are here. What does the latest research tell us about the role of the junction in the pathogenesis of MG? And can insights gained looking at research help us identify novel therapeutics, novel targets to support this and move forward? We know that complement activation is one of the key drivers in the pathophysiology of myasthenia, resulting in the architectural destruction of the junction, as I demonstrated yesterday. And this is mediated by the presence of antibody to a variety of determinants at the acetylcholine receptor. And we know that binding of antibody to the receptor complex activates C1q of the complement cascade, leading to the formation of the terminal complement complex or membrane attack complex, and then changes our peaks and valleys to sort of rolling hills, the resulting loss of receptor density, and therefore the inability in many instances of an end plate potential to reach action potential threshold and then generate the all or none response in muscle contraction. We know, and in my own experience, that many patients, and in some studies as many as 85% of them, who are in clinical remission, minimal symptom expression, whatever, still have significant abnormalities on single fiber EMG. And in fact, in all of my complement-treated patients, I have yet to see a normal single fiber EMG. When we've studied them serially, we see some improvement, but still there's other pathogenic processes, i.e. in part perhaps antibody, but I want you to think about some other mechanisms that may lead to ongoing synaptic inefficiency. So we know that with junctional injury, there are many compensatory mechanisms that kick into play. What we don't know is to what degree, at what time during the course of the illness. We know that there is increased presynaptic vesicular release to compensate for the lack of expression of acetylcholine receptors. We have upregulation of AChR, mRNA, and production. We have overexpression of a variety of muscle repair proteins at the junction. And in some papers, they talk about enhanced stem cell differentiation with delay in maturation. And there are a number of other neurotrophic factors and other molecules that have impact on the development and the sustainability of the neuromuscular junction. So, do these molecular and cellular changes that are been reported participate in the pathogenesis of MG? We don't know. Do they provide a mechanism of compensation? Theoretically, perhaps, but we don't know. These are areas of fruitful potential research interests. To what extent can compensatory mechanisms reverse or repair the neuromuscular junction? And I'll talk about some data in a little bit. And then how do these mechanisms differ from patient to patient? And then what's the clinical relevance of all of this? And we'll speak a little bit about that. We know that we have multiple tools to measure synaptic function. And in part, some of this has clinical relevance. End plate potential recordings, that's what I spent in my training years recording, miniature end plate potentials and EPPs. We have now jitter with single fiber EMG, jiggle if we're using concentric needle electrodes. We've always used rep-stim in the compound muscle action potential, its amplitude, its decrement, either by amplitude or by area, to look for synaptic failure. And then in some laboratories, look at twitch and tetanic force as a measure of synaptic efficacy in particular pathogenic mechanisms. And so evaluation of these functional properties may give us some clues based on morphology that we look at, based on biochemical alterations, etc. We need to marry this information with each other. It's a plea for cooperation among groups to pool resources from diverse backgrounds to see what we can come up with. And then the relative contributions of these mechanisms of synaptic blockade that I mentioned yesterday, antibody binding, internalization, and degradation of the receptor, turnover, and then complement activity. Who's playing the major role? When? And when you look at clinical trials, all of them to date have a significant percentage of patients that do not respond. If I'm clearing antibody in a plasma exchange trial or an FcRn trial, why do some 30-40% of patients not respond? I'm clearing the antibody out there. And to me, the failures are the most interesting population. And we don't study them. We say, okay, they didn't respond. They're non-responders. But they're telling us something, and that needs to be explored. Do the antibody mechanisms play the major role at a particular time throughout the course of the disease? Is it the same for the same patient throughout? I don't think so. I think there are those that predominate with antibody and those that predominate via complement and a whole bunch of them in between. And I think they shuttle back and forth based on whatever immune process is going on due to whatever event that is going on, either therapeutically or some adverse event. Is it sickness, illness, fever, infection, whatever? I think this is a very dynamic situation, but we have no proof of this. This is all hypothetical and rich for evaluation. This is old data. David Grobe, who was an internist at Maimonides, probably knew more about myasthenia than most neurologists. And this is his own personal data over the course of some 60 years. And there's no question that in his hands, patients treated improved here in the orange bars. And in the dark purple bars here, the rate of mortality diminished over the course of his lifetime. But those who achieved remission in blue, those who got better in red, or remained unchanged rather, didn't change. Those populations, they may flux from one to the other, but the percentages didn't change. And that's telling us something. We now have some data, and Renato Maragazza from Milano has published this, looking at the effects of complement inhibition in the REGAIN trial and looking at successive improvement in the 104 weeks after the blinded phase. So at the end of the 26 weeks, about 60% of patients were improved. Some 26% of patients were in minimal manifestations. And by the end of 130 weeks, 85% were improved and some 60% were in minimal manifestations. By what mechanism are we repairing the junction? This might suggest that we are, that it's taking that long to achieve it, so something architecturally is changing. Yet we have no proof. It's an area that needs to be evaluated. And so now that we've looked at some of these mechanisms of damage, let's look at clinical relevance. And defining these pathogenic mechanisms may allow us to tailor therapeutic strategies, but we need more information. There are two lines of thought in terms of the role of antibody with complement inhibition. This is data from Kevin O'Connor's lab at Yale, who suggests that there is an antibody level threshold to activate complement. And he has numbers of patients who are AChR positive who have low levels of antibody that do not activate the membrane attack complex. And those that with higher levels do. And he believes it's the level of antibody that may be driving this. And there's others who say, no, that's not true. And this is work from Nick Sanderson at the University of Basel, who believes that if you have antibody binding to a single epitope, or maybe two epitopes, you form dimers, you form linear chains, neither of which will activate complement. But if you have multiple epitopes that are being targeted, one can form these two-dimensional arrays I call pleated sheets, and these do activate complement. And so are there patients who can only express this or this, and they're more antibody dependent and not complement dependent? And it's these individuals who are more complement dependent and not antibody dependent, or do they flux? Do we have epitope switching? Do we have epitope expansion over the course of time? And do these patients here move to this state and then begin to activate complement at some time during the course of their disease? Or does an individual in this state move back to this state and then they're not complement dependent? One could surmise that if I can control antibody, B-cell depletion, FcRn inhibition, and clearly get rid of all of my antibody, can I control complement activation? Maybe, maybe not. Area for fruitful thought. And then what are the consequences of synaptic damage? We know that the regulation of muscle homeostasis and maintenance after nerve injury, it's a bidirectional process, and that the synaptic developments are promoting peripheral nerve regeneration, axonal sprouting, etc., targeting, the same with reinnervation. And so all of these mechanisms, we have no clue as to what their role is in myasthenia, but it stands to reason that perhaps they do play some role. And so are there irreversible structural changes in the junction after which you're long and gone? And Bud Rowland had some thoughts about that. Is there a threshold of damage, like I said, that you can recover, or is it no longer reversible? Can we regenerate synaptic folds entirely? It's not clear, though there is some data, as I suggested yesterday, that the earlier we can intervene, perhaps we can protect, promote, and salvage these neuromuscular junctions. There was the concept of an end plate myopathy. Bud Rowland, back in 56, 57, wrote a paper of patients with myasthenia that looked like muscular dystrophy. And I actually had one who had so much neck atrophy and weakness that if her head flopped forward, she could not lift it up and had to do it physically with her hands. We tend not to see that anymore, though there is evidence from studies that are being done that it still exists. if one looks at electron microscopy and other techniques to assess that. We know that there is coexistence of myopathy and myasthenia, inflammatory myopathies and myasthenia coexisted. That's how prednisone got started, treating the inflammatory myopathy, and lo and behold, the myasthenia got better. T.R. Johns at Virginia was a big proponent of that. And we know that checkpoint inhibitors can induce junctional abnormalities and myositis concomitantly. And many of us have seen those. And so there is this overlapping process. And we heard talks this morning about sarcopenia. And we really don't know what the etiology is of sarcopenia, but is it related to junctional abnormalities? And with aging, do we have alterations in our neuromuscular junction, which in the presence of myasthenia makes the outcome less desirable? Again, thoughts that need to be addressed. There are some, Lyer is his name, who believes that sarcopenia is a disease of synaptic transmission, first and foremost. And so what's the significance, the clinical significance in our patients? What's the significance of end plate change from a myopathic perspective, although not clinically observed in our patients with myasthenia? And so we need to look to the future and where we go. And so we need further work, as I said, to understand the role of antibody, the role of level, what it's targeting in terms of epitopes, and the switching that may occur. That whole process needs to be elucidated. We need to work in identifying biomarkers of disease activity, like Anna Punga discussed this morning with her microRNAs and other biomarkers. I'm desperate to find someone who has the capabilities to do regional PET scanning with ligands that are non-lethal to the junction and to complement that we can then do in vivo and look at receptor densities, etc. We haven't found the proper ligand yet. But then, much like the MS world, we need to take a more homeopathic approach, and we need to understand what's the role of calories, what's the role of exercise that we've heard about in the improvement and the stabilization of synaptic transmission. We need to look at mRNAs and rhabsin and its role. So there are a number of avenues, I think, that lead to potential fertile research in a collaborative fashion that we can address to the future to further understand this. So to go back to the first two questions that I posed, we know that damage to the synaptic transmission occurs architecturally. Andy Engel's elegant electron micrographs demonstrate it. But we don't know if this is reversible, partially or fully reversible, or not reversible. And we do know that this is due to complement activation, driven by autoantibody, but to what degree? And to what sustained effect is that? And then we need, of course, bioassays and biomarkers. And can we help identify, using all of this information, for better targets? And my belief is absolutely, but that's only going to come with time. What I'd like to leave you with is a program that we have now been running for 3 years. Pushpa is intimately involved with this as well, Rare Disease Connect in Neurology. It's a group of scientists, clinicians, PAGs, with an interest in MG in terms of education, in terms of science. We've met now 2 years. We're meeting in Berlin the end of November. There will be satellite programs here in the States that you may be interested in. Scanning that QR code will take you to the website and give you further information of it. So thank you very much.
Thank you so much for that talk. We'll open up the room for questions. So I guess the one question I would like to ask with these post-junctional folds, the challenge is how do we track that? You know, my hypothesis is post-junctional folds get flattened in aging. They clearly have been shown in myasthenia. It also happens with denervation. So is this just a process of denervation or innervation? But is that reversible, and is there something we can do about it? Is the big question.
Exactly.
So, I'm trying to think what my question is, but I was going to ask before you mentioned it, well, what about these folks that don't respond? And you basically cut me off and said, what about those folks that don't respond? So what about those folks that don't respond? I mean, no one dies anymore from myasthenia, do they? Less than 1%. No, you shouldn't. Yeah, exactly. So, but, you know, how many people don't respond to acetylcholinesterase inhibitors? Very small number. Whereas we're finding 30% don't respond to FC receptor or complement inhibitors. So we always knew there was more than just the antibodies because the antibodies don't correlate. So I don't know. I'm just asking you.
They don't correlate using the assays
we
currently have.
So I was just asking you to think out loud a little bit about why don't they respond?
Yeah, well, I think in part in terms of trials that it depends on what's modulating your abnormality. Is it complement attack or is it antibody mediated? And there are two extremes. And if one is on one and you're in the other trial, you're not going to respond. That's one hypothesis. The second is that there are other substances and other factors going on yet to be identified at the junction that modulates synaptic transmission. And we don't know that role. Do any of these people have end plate myopathy? We're not biopsying any of these people. We're not doing electron microscopy. In the old days, we biopsied everybody, motor point biopsies, and looked at the degeneration at the neuromuscular junction when I was a resident and saw lymphorages, for instance, sitting beneath nerve terminals, and then the architectural destruction that we saw. We never truly saw profound inflammatory responses, but we have lots of serological markers that say there is an inflammatory process to all of this, and that's why there are now trials looking at interleukin and other things. It's a big question mark. I mean, we need the young folk to get involved.
So one thing I'd like to compliment Dr. Howard on, he is the ultimate Switzerland of therapeutic trials in myasthenia gravis. You're amazing, and we are all grateful for you for that. I know this is a UCB talk. So UCB, looking at their post, they have both complement inhibitors and FC receptor blockers. So what do you think I'm not advising using both drugs in a person, but coming up with a new therapy that actually does both at the same time?
Well, for years, since I've been involved in the complement space since 2007, when, and I guess you were at that meeting in Cheshire, Connecticut, when we talked about it and designed phase 2. I think we need to think like oncology. We need multimodality therapy. We need to address the antibody, and we need to address complement. You can use all the complement inhibition in the world, you still have antibody. There's no way you can remove, at this point, all of the antibody. And so you're going to have complement activation. Now, there is technology being developed that will selectively bind to a specific antibody type called a CellDeg. And Sally Ward has been working on this. And so can you design a CellDeg that will go in and remove selectively AChR antibody? She's working on Musk at the moment. But that may get us a bit further. But I think both ends have to be addressed. As I said, we can treat with complement. People go into clinical remission, they still have some brittleness to them, and they have jitter. So we know we have synaptic failure. It is. Phenomenal problem. I wish I were 50 years younger.
Thank you so much.